I think I probably know a lot of you have been on this before. So again, I'm Dr. Finney, Pediatric Emergency Medicine and EMS Director at St. Louis Children's Hospital. I am going to talk to you guys today about pediatric drowning. A lot of these concepts that I'm going to discuss are applicable to both adults and pediatrics, although we all know, and if you guys have heard me talk on this before, there's a lot of respiratory pathophysiology and anatomy that's different in a pediatric patient. So I will try I'm going to direct this mainly at pediatrics, but know that the pre-hospital priorities really are the same across the board. So to get this started, so this is my daughter's picture, was taken 2 years ago, to give you guys sort of a scenario to bring this home. And I apologize in advance if anybody has experience, real life experience with a pediatric drowning. Hopefully it was at work and not part of your own family, but it is something that happens. So if it gets a little bit too intense or starts to feel a little sensitive, then please just log off or just tell me to talk about something else. We can switch topics. But this first case is really a made up case, but it's loosely based on a real life scenario. So you could think of a case where my daughter, she's outside in the backyard playing with my son, and they go behind the shed, and it had just rained the day before, and they're playing in the backyard and having a great time. And we had just had painters at the house a few days before, and they had put their paint buckets back behind the house. I see my daughter or my son come running up to the house, yelling and screaming, go out to the back of the house to find my daughter, feet out of the bucket, face down in what we think of a large painting bucket or something like that, with only a few inches of water in it. That's no longer breathing and without a pulse. That scenario, I know you guys are like, well, that's ridiculous, and that would never happen, but that does happen. And if you guys go to Home Depot and buy a big painting bucket or cement bucket, on the side of that bucket will be a picture of a child and an X through them getting in the bucket, because it does happen. So what's my point on that? The point is that drowning is quick, and it's silent, and it's deadly. And we're going to get into this as far as its relationship to pediatrics and what the priorities are in the management of those patients. So like I said, it's the #1 cause of death among children age 1 to 4, leading cause of death among teens. It has been declining over the last several years, like we talk about, but it is still a huge public health problem and a major cause of morbidity and mortality for pediatrics that is prevented. There was a 16-year retrospective pediatric study on immersion-related deaths, and I'm going to tell you the difference of that in a second. They recorded 82% occurred in children younger than 4 years of age, and 70% occurred at home, and 91% of those deaths were associated with a lack of parental supervision. That part, parental supervision, should really be in quotes, because most people think if they're nearby the body of water with their children, then that's supervision. And we know now that that is not appropriate, or not enough anyway. So I want to go through a couple terms, because you guys are going to document this incorrectly, not because you're bad paramedics, but because we are using confusing terms. And so I want to clarify this for you. So what is drowning? So it's a process resulting in primary respiratory impairment from submersion, meaning the oropharynx, the airway is below the surface of the water, or immersion, which is the the airway is above the surface of the water in a liquid medium. Okay. So the outcome of the event does not determine whether it's a drowning event or not. Okay. You don't have to die to have had a drowning event. So because of that, we don't use terms like near drowning, dry drowning, wet drowning, secondary drowning, passive drowning, silent drowning, or any other version of drowning that you may have heard. None of these terms apply anymore. If you get called to a pediatric patient who is submerged under a body of water for any period of time, that is a drowning event. Okay. So it doesn't matter if they die or they don't die. And stay away from all of these other terms. They're unnecessary. I'm going to go through some of this kind of fast just for the sake of time. It's a leading cause of morbidity and mortality. Obviously, it has a significant effect on our toddlers and our teenagers. And it's primarily those who are just about at walking age but not able to swim. And then our adolescents and teens who take more risk-taking behavior. You guys are probably going to occasionally get called for a real drowning event, meaning that a patient has died and you're doing cardiopulmonary resuscitation, but know that you're going to get called about 4 times as frequently for pediatric patients who suffer a drowning event, who are not necessarily in cardiopulmonary collapse and who still need to be transported, still need to be evaluated, but who are not receiving active CPR. And then about 1 out of 5 is going to end up getting admitted to the hospital of those patients who are more minor and just seen in the ED. I kind of said this, but it's a bimodal age distribution. So really little kids and older adolescents who engage in risk-taking behavior and also drug and alcohol use that causes CNS impairment. Those are the ones who are going to drown. And obviously our really little kids, they primarily drown in backyard pools, in buckets, like I talked about. And then they also can drown in the bathtub, which is a much more common area. Unfortunately, as with many things in healthcare, it affects our minority races and those of lower socioeconomic status. So you can see by this age distribution that it primarily affects those of minority race, unfortunately. This is a 2016 example, but just shows you kind of where the deaths occur. And this is really to show you that the more areas that have outdoor pools, California, Arizona, Texas, Florida, or exposure to bodies of water, obviously that's where more of these are going to occur. You might not have as many backyard swimming pools in Montana, so you don't have as many drowning events. All right, this is kind of already covered, but just shows you that we really haven't made a huge difference. We've made a difference in the older people and the really little, but 1 to 4 years of age, if you go back to 1999 all the way up to 2010, we're still seeing the same number of drowning events. So it's a really significant problem. I'm going to skip over that just for the sake of time. This just shows you where people are drowning. And I kind of already covered this, right? Little kids drown in bathtubs, swimming pools, older kids drowned in larger bodies of water because they have more risk-taking behaviors. So like I said, drowning is declining over the last 20 years due to prevention, but still 80% of drowning events remain preventable. And we really have to target the different age groups to determine how best to prevent drowning for that particular age group. Adult supervision, what I like to call touch supervision, is critical. You cannot stop a drowning event just by being in the vicinity. You have to be close enough to grab that child to stop that drowning event. So we call it touch supervision. And the more layers of prevention, the better, including self-latching or self-closing gates. That's a really critical one, and we'll talk about that in a minute. And for any of you who have had experience with this, children do not struggle when they drown, they sink completely silently. They literally just walk off the edge of the pool and sink straight to the bottom. And if you weren't standing there to see it, you won't even know that the child is in the pool. So it's very quick. What happens in a drowning event? And some of these are obvious, but it's important to go through them. So first is a panic event, right? So you struggle. For children, they struggle underneath the surface. You have voluntary breath holding. After that breath holding comes a subsequent episode of loss of consciousness. Once you lose consciousness, you lose your gag reflex or your ability to cough. Water then fills the airway. You get laryngospasm, causes aspiration of large amounts of water. Tissue anoxia, so absence of oxygen delivery to the brain. You can have the dive reflex, which we'll talk about here in a minute, and then tissue hypoxia from that anoxic event. That causes irreversible CNS damage around 5 minutes, 4 to 6 minutes or so. Once you've had that significant event, then there's injury to the endothelial cells of your alveoli. You wash out the surfactant that's responsible for that gas exchange at your alveolar level, and you cause leak around the alveoli, which causes significant pulmonary edema. Imagine a large amount of cold water just suddenly injected into your lungs, into your interstitial space. You get subsequent hypothermia, and then you get diuresis, which I don't know the pathophysiology behind the diuresis, so don't ask me on that one, but it also impacts your significant intravascular hypovolemia. So you get third spacing of fluid, but you're intravascular volume depleted. The anoxic event causes arrhythmias such as VFib, but that VFib quickly translates into asystole. So the primary hallmarks of a drowning event are asphyxia from going under the water, anoxic injury to your CNS system, hypothermia from the large amount of fluid that suddenly rushes into your thoracic space, into your lungs, and down the road, subsequent reperfusion injury after that event. So the pulmonary effects, so we talked a little bit about this, but you have abnormal surfactant function that causes increased endothelial permeability. What does that mean for you guys on a practical purpose? You wash out the alveoli in your lungs wash out the surfactant in your alveoli, which then allows for fluid to leak out of the alveoli into the space around your lung tissue. And this causes VQ mismatching. For those of you who have heard my respiratory talk, you know I've talked about VQ mismatching in the past. What that means, ventilation is the V, perfusion is the Q. So you are not perfusing areas that you are ventilating. There's not a one-to-one. In order to do normal respiration, you have to both ventilate an area of your lung and perfuse that area with blood in order to perform gas exchange and feed your end organs. That system falls apart and you get a disproportionate, you get blood still coming back to the lungs, but you have filled your lungs with fluid, so you get no gas exchange because there's no oxygen and carbon dioxide to exchange. There's just fluid in that area. And then ultimately, just in the way we see with our COPD exacerbations or our heart failure patients, you get poor lung compliance once that fluid builds up on your lungs, increasing hypercarbia or CO2 retention and hypoxia. You get ARDS, obvious for the obvious reasons of the fluid buildup on your lungs and the alveolar damage, and then the CNS hypoxia. The extent of the injury really depends, and this is where you guys matter, right? So this is, I don't fix drowning patients. They either come to the ED alive or dead, and I don't change that. You guys change it at the poolside, in the bathroom. That's where the real impact for this type of event occurs. And why? Because we know time to CPR matters in pediatric drowning events. How effective is your CPR? What is the extent of cerebral edema and hypothermia that they may have experienced? So all of those things are really, really important. For the sake of time, I'm not going to go through that. But we want to talk about sort of the treatments and outcomes that you might see. What matters? So bystander CPR. So if I go in the factors that are most important in a pediatric drowning event, bystander CPR is number one above all, and it's true in all pediatric cardiac arrest. Number two is EMS response to the scene to deliver high quality, effective ventilation and cardiopulmonary resuscitation. Okay. After that, nothing else matters. Now, there are other factors outside of our control, such as how long they were in the water and things like that, but we're not going to get in. Those are sort of some factors we'll discuss here in a minute. So the goals for you at the poolside, if you get called to a pediatric drowning event, get the patient out of the body of water, okay? Prevent further anoxic injury through adequate ventilation. So place an endotracheal tube or a supraglottic airway in these patients so that you can appropriately ventilate them. Don't do the stuff you saw on Baywatch 20 years ago where they start doing the Heimlich maneuver and, you know, like hitting people in the stomach to get them to throw up the water. That's a waste of your time. You will see people do it. That's for the TV shows and not for real life. All you're going to do is you're not going to do the things that matter. You're not going to do high quality CPR because you're sitting there doing the Heimlich maneuver thinking they're going to wake up, and you're going to cause them to aspirate more fluid into their lungs. So skip it completely, treat it like a cardiac arrest. And then you want to think about other potential causes of the drowning event while you're doing that resuscitation. Was it a seizure? Did they hit their head on the diving board? Is it a CNS depressant, some sort of toxic exposure that may have caused it? All those things need to be on your radar. And then get them warmed. Hypothermia kills just as much as anything else. So you need to make sure patients are warm, and they won't be, right? Because they just swallowed a ton of cold water, and their probably clothes are wet if they're wearing any clothes. So that's really, really important. Put the pads on, but no, it's probably not going to be a shockable rhythm unless you just got there and got them out of the pool early. It's almost always going to be asystole. So just get the pads on, identify that it is or is not a shockable rhythm, and move on. Okay. So shock, this gets a little bit into the emergency department care, but it's an important factor for you guys to consider. So the shock that, remember we talked about third spacing, hypovolemia, intravascular hypovolemia. So the volume of blood circulating in their vascular system is down. these patients end up in shock, and this can cause significant, this can worsen the anoxia and the hypoxia that they're already experiencing. So you want to really monitor their hemodynamic stability. You want to do good, high quality compressions to try and circulate the blood volume. And then I think I say it here in a minute. Yeah, balanced fluid resuscitation is really important. So not bolusing the heck out of them with a bunch of fluid, but balanced fluid resuscitation, because you don't want to overload the intravascular space, because again, they're leaking out, they're third spacing that fluid. So it's a balance that you have to strike. We talked a little bit about this, but hypothermia is an important thing to consider. It's associated with the duration of the submersion, obviously the temperature of the body of water, the size of the child, right? Smaller children have a higher body surface area ratio than an adult, so they have more insensible losses. They lose heat through their skin more easily, and you want to rewarm these patients. In the pre-hospital setting, what I would say is turn up the heat in the ambulance, right? So you're not going to bake them. Doesn't matter. Just you're hopefully only driving them 10, 15 minutes to the emergency department. So go ahead and get the patient warmed up in the back of the ambulance as quickly as possible. Okay. The mechanism is important, but it's not going to change your initial management, except if it's concerned for a C-spine injury. In those situations where you think that there's cervical injury, you want to put those patients in a collar. How do you know whether there's concern for a cervical injury? Was there a boating accident? Did they drive the ATV in the water? Did they hit their head on something before they went in the water? Was it a dive into a shallow body of water? Those ones you should consider a cervical spine injury. Outside of that, the toddler in the swimming pool, the toddler in the pool in the backyard, those types of things that we might see, there is no concern and very, very low risk of cervical spine injury, and it should not be prioritized. Okay, so this is what kills people, HIE, so hypoxic ischemic encephalopathy. This is what we're trying to prevent, because if you keep them alive to the emergency department, if something kills them down the road, this is what's going to do it. So this is diffuse anoxic injury to the CNS system, which causes significant brain swelling and edema. It usually happens within the first 24 to 48 hours. I had a drowning patient, unfortunately, about 2 years ago that showed up to the emergency department after a prolonged downtime, put them in the CT scanner, and they had loss of that gray-white matter differentiation, which is characteristic of hypoxic ischemic encephalopathy. And there's nothing to do for that patient. It's a redirection of care at that point. So this is what's ultimately going to kill them. And this is what you want to try and prevent on scene. Okay, this stuff you guys don't have to worry about. This is for in-hospital monitoring. I wouldn't focus pre-hospital on any pharmacologic therapies. If you get them back, then you treat them post-ROSC the way you would any patient to maintain normal perfusion. And if you want to use epinephrine or something like that to do that, push dose pressors, that kind of stuff is fine, but it shouldn't be a priority of your management. Focus on the things that make a difference. If you're curious, what we're going to do in the emergency department is we're going to watch these patients for about 4 to 6 hours. Kids who look well, who came into the emergency department with a normal GCS, those kids often go home after 6 hours. We know that at about that 6-hour point, patients will develop any respiratory symptoms if there are going to be any, and then they would be admitted. We don't give antibiotics unless there's concern for an overlying bacterial infection or anything like that. I think I already kind of covered this. So for the sake of time, I'm just going to, it's a good picture to show. So you guys can see there that the fluid leaks into the alveoli in the bottom right. And you can see how that, the same way a CHF patient with significant pulmonary edema is going to be unable to perform gas exchange and is going to have that VQ mismatch, the same thing's going to happen in these patients. So what do you do for that? Well, if you have a ventilator or you get the patient back and put them on a ventilator, you're going to want to treat for ARDS, which is going to you're going to give higher P to those patients. In the emergency department, that's what we're going to do. We're going to ventilate with higher pressures to try and open up a lot of these collapsed alveoli that have undergone injury from the fluid. Airway is the most important in a pediatric patient who's undergone a drowning event. In fact, it's so important that if you read the NASEMSO model guidelines for pre-hospital care, they actually recommend, and I agree, if you get in the water to get these patients out, you should administer 2 or 3 rescue breaths on the way to the side of the pool or to whatever body of water it is, because if you can get them ventilated, then you might actually be able to reverse or restart the heart just from that. So I don't know if you guys have ever had any experience where you have a pediatric patient who's in cardiac arrest. Once you get the definitive airway in place and get that patient ventilated with a couple good breaths, a lot of times we can actually get restart of spontaneous circulation just from that. So knowing that the primary cause of all of this is anoxia and hypoxia, once you get those treated, treatment of those is the primary goal in the pre-hospital setting. Okay, and I think I covered all of these other things. Balanced fluid resuscitation is key. Just don't hit them with a ton of fluid. They may have seizures from the anoxia. You want to treat those seizures the same way you treat any other seizure. So, benzodiazepines, I recommend intramuscular benzodiazepines, easy first option. And then what's the good news? Well, the good news really depends upon our pre-hospital providers. If you guys can deliver me a patient who has, and I put GCS 13 or higher here, it's really if you get them to me with a GCS of 5 or 6 or higher, and they have a pulse, there's a really good chance that those patients are going to have a good neurologic outcome. Okay. If you bring me a patient who's been down for 25 minutes, who is asystolic and who has a acidosis on our initial blood gas, that patient almost has very, very poor outcomes. If they even survive, they will survive neurologically devastated. So the goals pre-hospital are the same for a pediatric cardiac arrest as a pediatric drowning event: ventilation, perfusion, and trying to get ROSC early to deliver those patients. Now, the one thing I will say that I think is different in a pediatric drowning event is this is a situation where, yes, you want to prioritize your on-scene management, but you want to be looking towards getting them to the hospital sooner rather than later. Okay. So I know we talk about pediatric cardiac arrest events. We want to stay in play, get ROSC on scene, try and save those patients the same way we do for an adults. In a pediatric drowning event, yes, you want to prioritize those initial interventions, but when you can, when you're in a position to move them, you want to move them and get them to the emergency department where we can do more advanced interventions like getting maybe you guys can't place an endotracheal tube or you're unsuccessful. So getting an advanced airway in place, vasopressors, getting them ECMO if it's available, those kinds of things might be beneficial. Submersion time longer than five minutes has a poor outcome. You want to be aggressive with your resuscitation. This is stuff we'll do in the emergency department and the ICU with serial neurologic exams, because remember I said that HIE first 24 to 48 hours is where that's going to show up. And then like I talked about a little bit already, a drowning pediatric cardiac arrest has a lot of similarities to a regular cardiac arrest with some important differences. Ventilation is that key first intervention. So, we talk about in a pediatric cardiac arrest, straightforward, medical cardiac arrest, that we want to get on scene, get compression started, get an airway, get epi, and that all of those are critical priorities. In a drowning event, you want to get them out of the water, get them ventilated as quickly as possible, and then get them warmed and get them transported to the hospital. And during that process, doing high quality CPR is going to be key. Okay. So, some other factors that are associated with the drowning, I talked about acidosis, a pH less than 7.1 is bad, persistent apnea in the emergency department, so no respiratory effort, resuscitation at a time that is prolonged, so 25 minutes or more, and then time to effective BLS support. So you guys getting on scene and ventilating and doing compression on these patients. Notice it doesn't say time to effective ALS on scene evaluation. This is basic life support for these patients, good, adequate ventilation. And if you guys have heard my respiratory talk, I hammer to talk about adequate, appropriate, effective ventilation with the BVM. That's what's going to be life-saving for these patients. And then there's always some sequelae, neurologic devastation, chronic lung disease. Those are really important. So how do we prevent this? You build a wall. That's really the bottom line. And you need to make sure that it's on all four sides. It's at least 4 feet high and it's less than 4 inches off the ground. Those are really, really important. And then it's self-closing and self-latching, and then it's climb resistant. Okay. So you guys, our firefighters and our paramedics do a lot of outreach. Remember, this is a public health crisis. This is a problem of injury prevention. the best treatment for drowning is to prevent the drowning initially. So if you guys can cover this important stuff with your families when you are on scene, not on scene on a drowning event, but when you're like out in the community doing education and teaching, covering drowning and safe prevention with barriers to bodies of water is so critical. And then teaching bystander CPR, because that's another huge intervention that's going to be important. Swim lessons are helpful, but everybody swims at a different age, and kids don't all have the same motor development at a certain age. So if I put my 3-year-old in swim lessons, they may get 10% out of it. If I put, another kid's 3-year-old in it, they might, be great swimmers by the end of it. So you can't say if we get everybody swim lessons, that's going to stop it. And there's no benefit for kids under 1 year. Now, I know there's a big push to do this sort of survival swimming where they'll take, very little kids and put them in the pool and teach them how to float. This is a new intervention, and there's no evidence to say that it makes a difference long term. Definitely makes us feel better, but there's no evidence to say that it actually prevents drowning. Always have your children wearing life jackets when they're around bodies of water. It can prevent up to 85% of injuries. Okay, so just to recap, priorities for EMS: quick response, getting that patient out of the body of water, prompt, effective ventilation with a supraglottic airway or just bag valve mask ventilation. If you've got somebody who's an expert in endotracheal intubation and you're like, this guy works on a pediatric transport team or whatever it might be, and you want to do an endotracheal intubation, then that's fine. But know that prolonged attempts at intubation cause hypoxia and anoxia, and that's exactly what we're trying to prevent. So don't shoot yourself in the foot. Get the oxygen to the brain the fastest, most effective way possible. Okay, and then high quality CPR, warming those patients, balanced fluid resuscitation, and prompt transport to a pediatric center is going to be critical. Any questions about that?